Hey guys, Dallas Holiday here, fourth year emergency medicine resident at Midwestern University. Today we are going to be talking a little bit about ultrasound related to neurology for our neurology month. Some of this is going to be relevant for neurology, and then some of it's also going to be more specifically aimed at ocular ultrasound, mostly because we have these big thick skulls that prevent us from directly ultrasounding the brain. Although if you're on PICU and you get the opportunity to see a brain ultrasound, which they do on some of the neonates that their fontanelles haven't closed yet, pretty cool. So I recommend you check it out if you get the opportunity, but probably not something we're really going to be doing in the emergency room. So without further ado, let's get started. So objectives for this lecture, we're going to learn some basic anatomy, technique, and pathology related to ocular ultrasound. As with any procedure, we want to know when we should not be doing ocular ultrasound, and ultimately I want you to do ultrasounds on your patient. First, we're going to talk about technique of the ultrasound itself. So we're going to be using the high-frequency linear probe. You want to be scanning through a closed eyelid. Please do not place the probe directly on someone's eyeball. That would be very uncomfortable for everyone involved. You're going to take transverse and sagittal views. The patient's typically going to be in a supine position looking straight ahead at the probe. The probe is going to be completely perpendicular to the eye. And you want to fan through the entire eye looking for any pathology. So this is essentially what your setup is going to look like. You get your linear probe there. You want to have that probe marker typically oriented to the patient's right or toward their head. And I recommend using their cheekbone to sort of rest your hypothenar eminence, to keep your hands steady throughout the ultrasound, and to also prevent you from placing pressure onto the eye. The last thing you want to do is be putting any pressure on that eye. You want to use lots and lots of gel, because again, the probe shouldn't be actually making contact with the eyelid. It should just be making contact with the gel. The ocular ultrasound is looking at structures that are so superficial you don't need to actually contact the skin. Unfortunately, the gel can be irritating to the eye, so you want to attempt to keep it out of the eye, and there are a couple of different ways you can do this. Firstly, my preferred way is to place a tegaderm over the closed eyelid and then place your gel on top. Just want to be sure to avoid bubbles, because again, those will impede your ultrasound. And additionally, don't stick it real heavily to their eyelashes or their eyebrows. Nobody wants a complimentary eyebrow wax in the emergency room. That's definitely outside of our scope of practice. Also, literature says that you can use petroleum jelly instead of the gel, which will be less irritating. To me, that just sounds like a mess to clean up. And additionally, as clean as we like to think our probes are, I myself would want a tegaderm down between my eyeball and the ultrasound probe in an emergency room. But anyways, that's my trick of choice. Do whatever works for you, just to get the ultrasound done safely. So here's your normal anatomy. You've got your cornea there, followed by the anterior chamber, your lens and your iris, your vitreous body, which should be hypoechoic because it should just be fluid, your retina, which should be kind of tacked down the back there, your optic nerve and your retrobulbar space. You can identify the optic nerve there because it's a slightly hypoechoic compared to the retrobulbar space. I know that can be challenging to appreciate, but don't worry, I'm going to show you some more images of that. Contraindications. If you think you have a globe rupture, realistically, you probably shouldn't be doing an ultrasound of the eye, because anytime you place pressure on that eye, vitreous humor is going to leak out. Vitreous humor is an irreplaceable body fluid. Once you lose it, it's gone. So you do not want to be putting pressure on anyone's eyeball if you think they have a globe rupture. Now, there are some emergency physicians out there that argue that if you use a lot of gel, you should be able to get this exam without placing pressure on the eye. However, in my mind, I think about it now, the patient has all this gel over their eye. You're going to have to get that off so ophthalmology can do their exam, and then you're going to be wiping that off. I don't know. To me, I just wouldn't even go there myself, especially because ophtho is going to be furious when you call them and you tell them what you've done. Also, if there's a lot of periorbital emphysema, you don't want to be doing the ultrasound exam, not so much because it's going to harm the patient, but because the air is going to impede the ultrasounds and you're not going to get a good exam. So this time around, I thought I would throw in some cases to help kind of focus us in on what patient's ultrasound is going to be helpful with. I know it's a little new compared to last time. Again, this is a work in progress. So if you don't think it works, let me know. If you do think it works, let me know. I'm fine with it either way. So our first case is a 44-year-old female. She's presenting for evaluation of persistent daily headaches for the last month. She describes the pain as frontal and bilateral in location, throbbing in nature, and notices it's worse in the morning, associated with some nausea and vomiting. Physical exam does not reveal any focal neurologic deficits or nuchal rigidity, but fundoscopic exam is limited by her discomfort. So how can ultrasound help us with this patient? Well, the differential diagnosis for headache is going to be extensive, and an exhaustive discussion of that is beyond the scope of this lecture. However, ocular ultrasound is a fantastic adjunct to your H&P for headache patients because fundoscopic exams often are limited by equipment availability, operator comfort, and patient tolerance of the exam itself. Ultrasound is a quick and non-invasive, easy-to-learn bedside evaluation that can be done rapidly to identify papilledema in these patients, which would certainly be concerning even with a normal physical exam. So as you might have guessed, we're going to talk about papilledema. So when you're measuring your optic nerve sheath diameter, you're going to be using that high-frequency linear probe. You want to catch it in the transverse view. You're going to use your calipers to measure 3 millimeters posterior to the retina, and then you're going to measure the optic nerve sheath diameter at that point, 3 millimeters posterior. Normal optic nerve diameter is less than 5 millimeters, and optic nerve diameter greater than 5 millimeters is consistent with papilledema. Now, that actual papilledema number varies a little bit depending on what literature you're looking at, anywhere from 5 to 6.5. But certainly anything greater than 5 is going to raise a little red flag, and you might get a little more concerned for that patient. So again, here's our normal anatomy. You've got your ultrasound probe, closed lid, everything in the anterior portion. You've got your retina in the back there, and then your optic nerve and your optic sheath. So again, you want to measure 3 millimeters posterior to the retina, and then at that point, you're going to measure the optic nerve sheath, and you want that to be less than 5 millimeters. Why does this work? Well, remember, when you have increased intracranial pressure, that pressure transmits to the optic nerve and can push CSF into that area, causing swelling. So this is useful for us because we can measure it with the ultrasound. And here's an actual ultrasound image of the optic nerve there. So again, remember, it's going to be slightly hypoechoic. You want to measure 3 millimeters posterior to the retina, and then you're going to measure that sheath across, and it should be less than 5 millimeters. So here's an actual ultrasound example where they've used their calipers. You can see they use their first set of calipers to measure 3 millimeters posterior to the retina. Then they use their second set of calipers, the B calipers there, to measure across. And as you can see, this one is normal. It's 0.41 centimeters or 4.1 millimeters. So that's appropriate. That's good. And when you're using your calipers, there should be a caliper button on any of the machines. You just find it, hit caliper, and it'll bring your calipers up. And then there's going to be a roller ball or a touch pad to actually move the calipers around. So again, here you can see their A calipers. They measured 3 millimeters posterior to the retina there. And then they use their B calipers to measure the optic nerve sheath diameter, which here is demonstrating abnormal, which is 7.1 millimeters there. Additionally, this image demonstrates what's called the crescent sign, which is basically swelling of the optic disc. It's that little bump that you can see just above that A caliper. That shouldn't be swollen like that. That should be nice and smooth. That's also consistent with papilledema. I do recommend that you, number one, figure out where your caliper buttons are and how to use your calipers before you go in the room so you're not fumbling in front of the patient. And then number two, do freeze your image to use the calipers because using it on a real-time image is going to be pretty challenging. So how useful is this? Well, here's a paper where they took 50 patients and they measured the optic nerve sheath diameter, and then they did an LP and measured opening pressures. So they basically found that if there was an optic nerve sheath diameter of greater than 5.5 millimeters, it predicted an opening pressure of greater than 20 centimeters of water with 100% specificity and sensitivity, which is actually pretty impressive considering how limited fundoscopic exam can be in the emergency room for papilledema. So definitely something you want to be thinking about with your patients.